Aloha kako. Thank you very much for having me. It is my humblest honor to be here. And thank you to Dr. Henshaw as well for hosting such a fine event. Well, today we're going to be talking about some exciting advances in dentistry and dental medicine today, what's been available in the past, what's available now, and what's in the pipeline for the future. It is a very exciting time for our specialty. I'm going to move forward. We're going to describe some specialties within dentistry and what those involve. I want to start by emphasizing the importance of prevention, of course. Prevention in dentistry is key in your oral health. It matters not only for your teeth and your mouth and your jaws, however, systemically throughout your body, the mouth is definitely connected. A lot of overwhelming evidence-based research within the last 8 to 9 years has been coming out showing the systemic links between periodontal gum disease and other systemic risk factors such as cardiovascular disease, non-insulin dependent diabetes mellitus, especially type 2, as well as some other interesting links to some certain cancers in the pancreas. So within preventative dentistry, there are several facets that we're going to touch upon, some being what can be done at home and others are what can be done in the dental practice setting. Definitely within your home environment, oral dentifrice or keeping the teeth clean and the gums supporting the teeth is of the utmost importance. Brushing, we now advocate at a minimum twice a day, morning and night, ideally after breakfast and dinner, for a total of 2 minutes. A recent study suggests that most people, though they're directed to brush for 2 minutes at a time, usually average about 47 seconds. So that's not enough, and we'd like to definitely see that increased. And as well, another important key fact is to be brushing very gently at the gum line for a 2 minute period and flossing ideally twice a day. Dental sealants is a preventative measure within the scope of the dental practice setting. Dental sealants have been used for many, many decades, mostly in our pediatric population of patients. And it's a simple process of adhering a resin plastic coating to the pits and fissures, the deepest grooves on the chewing surfaces of our teeth, to greatly prevent the chance of developing caries, or as we call them, caries cavities, in the areas that are more susceptible and prone to developing decay. Bacteria within our mouth, we live symbiotically with bacteria. We need it to digest our food and function daily. However, there's always a constant struggle as dentists to keep that balance in check, especially the damage that bacteria cause. A nice way that we prevent the damage of bacteria or the demineralization of the protective shell of our teeth that we refer to as enamel is via the administration of fluoride. Fluoridation in the public water system in our great state, unfortunately, is not there yet. I'm a strong advocate for it because of its importance and overwhelming evidence-based research over the past 70 years. Our past Surgeon General, Dr. Sangster, mentioned how it was one of the 10 greatest public health advancements of humanity. So I am a big advocate of fluoridating the public water system in the state of Hawaii. We're not saying to excessively fluoridate anybody, but within a normal limit that proves that the remineralization of our enamel can be achieved by such a task. How does the enamel, the protective shell, degrade over time? Well, it mainly degrades over time by the acids in our foods, sugars in the mouth that are retained and left by a carbohydrate-rich diet, as well as by the erosion of the acid that the bacteria in our mouth give off. And the bacteria in our mouth, every human has it. It's on a clear pellicle film called plaque. So we want to keep the plaque at bay and the erosion at a minimum. Some oral hygiene products that have been new and recent to the dental world, one of the neatest things is a dental floss pick, or a pre-strung flossing device. It's a small little plastic instrument about an inch or two in diameter, and it holds a pre-tightened piece of floss that patients are having a much easier time keeping their teeth clean when they weren't before with the older fashioned string you had to wrap around your fingers. Additionally, for our aging population where dexterity may be an issue, it is a significant improvement. As have been recent advances in toothbrush technology, I'm sure everyone is aware of electric toothbrushes and their importance. They oftentimes work with a mode of cleaning called sonication. It's not only the brush that's manually debriding the plaque and debris from your teeth, it's also the function of toothpaste and water and your saliva pushing through the sluiceways, or the areas in between your teeth, to push away the plaque that traditional manual brushing could not successfully get to. Another topic that's of great importance is cleaning your tongue. How many in here clean your tongue by a raise of hands twice a day? The tongue is probably the largest harboring area in the mouth that contributes to halitosis, bad breath, because of its nature and anatomy. It has a great surface area from the papilla, the taste buds on the tongue. So we recommend brushing the tongue twice a day for at least 5 to 10 seconds each time. With the traditional toothpaste as well is fine. And of course, the majority of prevention is in your court here to seek treatment for a biannual, twice-a-year prophylaxis cleaning, and manually having the dentist and hygienists debride away the plaque and tartar that builds up inevitably in every human. Below the gum line especially, the gums of our teeth have a free collar that attaches around the neck of our teeth called a sulcus. And that's what you get cleaned when you go to the dentist. That's what you have checked during the comprehensive periodontal examination via a probe. So if you've ever been to the dentist and you feel them kind of poking around the gums, there's 3 surfaces on the cheek side of your teeth and 3 surfaces on the lingual tongue side of your teeth. We measure to check the health status, the attachment status of your gums. That's the major indicative check we do, an examination we do to let us know if there is any active periodontal or gum disease developing. Here's an example of an electric toothbrush and a fluoridated over-the-counter toothpaste. Most toothpastes nowadays do contain fluoride in them, which again serves to help remineralize the teeth temporarily while it's adhered to the surface of the enamel. An electric toothbrush there, they come in different sizes. As far as the head of the brush that are oftentimes interchangeable and replaceable, we recommend at a minimum every 3 months to change the head of your toothbrush. And most importantly, we want to go very gentle with the toothbrush. We have seen an uptick in recession caused by the gums being eroded away through heavy brushing. Okay. So we want to make sure that the brushing is done with a feather touch, but thoroughly. And that's why we say, well, you know, a majority of the people have spend about 47 seconds on their teeth. You spend that extra minute and 15 seconds and you can be all that much more thorough. Mouthwash is a great thing as well. It helps remove the plaque and bacteria in between the teeth and in between the sluiceways of the teeth where toothbrush cannot successfully get. And then lastly, one of my favorite oral dentifrice tools is the water pick, which has been around for decades. Nowadays, they're quite inexpensive and they're often cordless. Within the reservoir, some patients, as directed by their dentist, can even put in a prescription mouthwash dilution solution to help irrigate the gums more thoroughly. So brushing, flossing, and water picking should be the way to go twice a day. So we recommend about 4 minutes in the morning and 4 minutes in the night. And that's a great preventative method to retain a majority of your teeth throughout your life. So when do we report a problem to your dental or primary care physician? Really, I'd say as soon as you start noticing significant changes within the body, within the mouth, a sign that a tooth is aching or a gum is paining is your body's way of telling you that something abnormal is occurring. And it is good to report that immediately. Though rare, complications in the body can occur from the start of a dental infection that can turn into an abscess or a pus-filled pocket that systemically can spread to the rest of the body. The onset of symptoms that don't reduce within seconds to minutes on a tooth, for example, if you have a toothache, is something of concern, and that's what you immediately report. The tooth is quite resilient, assuming it's vital and healthy, and the integrity within the tooth system is intact. A resilient tooth will have a certain ability to heal itself within the progenitor cells and the pulpal nerve tissue of the tooth. However, certain types of trauma, certain types of toothaches are hard to discern definitively in your teeth due to the limited type of pain fibers the anatomy of the tooth itself is made of. So it could be a toothache from a cavity or from a fracture or an injury that the brain only registers as an ache. Pre-existing health conditions is a very important thing. Again, always to report to your dental or medical physician. Pre-existing conditions contribute significantly in the oral environment. We notice more as well in the aging population, 60 plus, a decrease in the amount of saliva. And saliva plays a massive role in our optimal oral health. Saliva is 99+% water. However, it has an extremely important component of your body's own antibiotic features called immunoglobulin A. That's what helps prevent against viruses and bacterial infections. And when we have a decrease in the saliva or a decrease or change in the type of saliva that's being excreted, it's a concern. So something good to mention to your primary care physician or dental physician, so we can talk about options available to help rehydrate that oral environment to keep your mouth ideally safe. And then, of course, you want to disclose any medical changes. It's all important. That's all interconnected. Patients, for example, that may have had a recent surgery or a prosthetic placed somewhere in the body should ideally be on a certain type of prophylactic or preventative antibiotic medication therapy that's given systemically at least an hour before their dental cleaning prophylaxis or any dental treatment, just to prevent the chance of systemic infections to occur. So again, disclosing changes in the medical history and updating the medical history yearly is of key importance. What are the causes of dry mouth? Well, there are many causes. Obviously, many have heard cancer treatments, radiotherapy can damage the salivary glands. There's 4 major salivary glands in our mouths, 2 on the left, 2 on the right. They're at the base of the mandible of the bottom jaw, and then 1 on the internal aspect of the cheek, the parotid glands. They get damaged during cancer therapies. They are also significantly altered with the administration or taking of over 300 different medications most commonly prescribed in the United States, let alone the world. So we want to be very privy of the causes of that, and patients with xerostomia, dry mouth, should be increasing their daily care as well as their prophylaxis schedule at the dental office, their cleaning schedule, perhaps instead of twice a year, as many as 4 times a year. Is flossing important? Well, that's an interesting topic because there was some debate recently in the news media saying that flossing is actually not important. I like to be very clear and clarify that paper, that's wrong. Flossing is extremely important, and it's an adjunctive to keeping your teeth clean. Of course, it has to be done correctly. The paper cited an incorrect manner of flossing, which could be damaging, and I completely agree, as driving incorrectly could also render you in an accident. So flossing correctly is important daily. Let's talk a little bit about plaque before we get into some more specifics in dentistry. Plaque, again, a biofilm that occurs in our teeth. It's a shell of bacteria. Bacteria are extremely small, so millions and millions of bacteria on one surface of one tooth. The soft plaque is normal, and we debride that easily with the manual brush technique. However, the hardened plaque, called calculus or tartar, supersaturated by the calcium ions in our saliva, are more damage-causing and detrimental to our supporting structures, not only of our teeth, but the supporting bony structures that support our teeth and our jaws. The type of bacteria change as the environment of plaque changes. So the harder the tartar, the more dangerous the bacteria. They live more in an anoxic or oxygen-depleted environment. And that's the bacteria that releases toxins that cause the bloodstream in your jaws to register inflammatory signals, so your body surmounts its own natural, healthy immune response of moving away from that insulting agent. That essentially is called bone loss or periodontal disease. And it starts early on as gingivitis, as a chronic inflammation of the soft tissues. Left unaddressed and unremoved, it can turn into more aggressive periodontal disease, which has the detrimental systemic effects to the body. Okay, so how often do we diagnose dental disease? Definitely, it's very patient by patient. A person that has more risk or is more prone to developing cavities may want to have their x-rays done perhaps twice a year. A person with no cavities, has never had a history, can go as little as once every 2 years. But detection is the key, and nowadays we have digital radiology, digital x-rays, which function at a much higher speed than traditional old-fashioned radiograph x-rays. The advantage of getting a full series of digital x-rays is to allow your clinician to completely diagnose in a far more thorough manner, where we were limited by the issues and risks of radiation with the prior technologies of the past. There are several different types of x-rays available. You may have heard the terms. A periapical or bite wing x-ray is what's used in the traditional set of films we take to examine your teeth and the surrounding structures that support the tooth. A panoramic x-ray is the machine that goes around your head. Often now with the digital types of panoramic x-rays, takes about 12 to 15 seconds. And it helps also determine if there's any tumor growths or cancers or abnormalities within the jaw structures of the mandible and maxilla. And lastly, my favorite toy in dentistry and dental medicine is the cone beam CT scan. It's a computed tomography scan, or essentially a CAT scan of your jaws. And it helps us detect the density, and thickness, and volume, and integrity of the bony structures, not only in diagnosing for a disease, but also in planning for some more elaborate dental procedures, which we're going to be talking about a little bit later in this lecture. A lot of questions about bad breath. What is it caused by? We refer to bad breath as halitosis, and it can be caused by a plethora of issues. Obviously, in medicine, we always want to address common things that occur commonly. So if you have bad breath and we have an issue with it, you'd report it to your dentist, and we do a thorough examination to rule out that there's no infection within a tooth, a cavity, abscess in the gum. If we rule that out, then we next look to the successive line being the tonsils. Tonsils, as most people have, the glandular tissues in the back of the throat have tonsillar crypts or crevices that can develop little plaques within them. If those plaques are left untreated, they can cause chronic inflammation within the tonsils, sometimes necessitating removal of the tonsils. So again, important to disclose all the changes in your oral health history to your practitioners. Another cause of bad breath could be the Helicobacter pylori. It's a bacteria that's mostly found in the duodenum of the stomach. And you can have a urea odor in the breath. There is now a breath test that we can do to check the levels of H. pylori, called the urea breath test, as well as a blood test that can be done at your primary care physician, and is now oftentimes successfully treated with antibiotics. So bad breath may not exclusively be related to just your teeth or your gums. Again, good to disclose those things. Sometimes bad breath, if everything else is ruled out in the integumentary system, we can do something called a periodontal pathogen test, where there's a genetic test that tests over 20 different bacterial variants in your gums that can attribute to bad breath. Okay, gums bleeding. Is it bad? It's oftentimes bad if your gums bleed. There are several underlying causes why gums can bleed. Number one cause is inflammation and disease. There are some medications that have a side effect of inflammation of the gums, some anti-epileptic medications, Dilantin, for example. There are also issues of patients that smoke a lot that can have change in the oral mucosal environment causing gums to bleed. What does a deep pocket mean? When you go to the dentist, they say we have to do a deeper cleaning than usual. A deep pocket is the loss, again, like we just talked about prior, the function of gum disease, your body's own immune response being surmounted, moving it away from the insulting agent. So your body has a healthy response. Unfortunately, the result is gum disease or the loss of bone when that plaque and tartar is not removed. Now, you can be doing everything at home correctly and still have periodontal gum disease because there is a large genetic predisposition as well that can attribute to periodontal gum disease. Unfortunately, for that cohort of patients, we're just going to recommend more frequent cleanings to prevent that soft plaque that's in a hard-to-reach area where the toothbrush bristles can't get to from turning into that hard calculus or hard tartar that's more causative of a problem and can continue the periodontal bone loss. We touched about all toothaches being caused by a cavity. Again, that's not the case. There's only a couple of pain fibers within the teeth themselves that attribute to an ache, register a pain. The C delta fibers in the tooth register to the brain that there is an ache. Again, pain lasting seconds with the resolve or reduction to normal are much more mitigated. However, pain that lasts more than a few seconds to minutes is something that should be reported immediately. What happens, the body of the tooth is made of small little tubular structures. The body of the tooth we refer to as dentin, that makes up 80 to 90% of most of your tooth. And the thin protective shell of enamel is only on the surface of the tooth that's above the gum line, called the clinical crown of the tooth. So the enamel does not really have fibers to allow movement of the liquid within those little tubes to the nerve within the center of the tooth. The body of the tooth, however, if exposed perhaps by recession, which many people have in our community, recession of the gums, you wonder why the root of the tooth is exposed and why it's more exquisitely sensitive to cold or to sweet. And sometimes your dentist may say, you don't have a cavity, but you still need a filling. Now, why is that? Well, that's because the root of the tooth is exposed. So within the roots of our teeth, within the body of our teeth of dentin, a dentinal fluid, mostly comprised of water, moves with an osmotic and oncotic gradient change. So be it a temperature change, hot to cold very quickly in the mouth, salty to sweet environment very quickly in the mouth, those can all register movements of that fluid in the body of the tooth that registers an ache to the brain. We'll talk a little bit about the materials we have in dentistry available today. We have a great dynamic shift from the old-fashioned metal, mercury, silver fillings. Older-fashioned silver fillings, 50% made of mercury, the other percentage copper and tin, and an amalgamation of metals, how it gets its name, amalgam, a Latin mixture of different metals, and they're bonded by the mercury that's packed into a tooth that's drilled very large at the base and very narrow at the top, so when the soft metal hardens, it's kind of a lock and key in place. The problem with the older-fashioned metals that got most of us through our youth well and kept our teeth in place is that metals have a larger expansion coefficient of contracting and expanding with the hot and cold environments our mouths are continuously exposed to. And over time, they can cause fractures to occur and Craig's lines to occur that develop into fractures. Additionally, there are now safer alternatives to metal fillings, which we advocate much more frequently, especially resin plastics. So resin's a combination of certain types of plastics. Bis-GMA, bisphenol A, methyl methacrylate is the main component. However, there are even newer advances that are changing the resin delivery method of dentistry. Certain ones are porcelain and especially now zirconia dioxide, an oxide of metal but tooth-colored in nature and very strong as most metals. They don't have the toxic elements that certain types of resins of the past did either, and they tend to hold up and resist wear, erosion, and fracture resistance quite a bit more than the older-fashioned plastic fillings. So there is more of a dynamic shift now and using more zirconia and porcelain-based products in dentistry. We also have in our geriatric population or patients that perhaps have a decreased dexterity of keeping their teeth clean, a neat material called glass ionomers that have been around for a long time. It's basically a silicate of glass that often is used with a fluoride-releasing carrier that helps remineralize teeth in patients that have a hard time keeping that bacteria-producing plaque off the teeth. So there are some advances, again, to disclose dry mouth or changes in your mouth or changes in your dexterity important. So we know which materials to selectively choose for that specific patient. You can tailor your treatment now based on your overall medical history. We have a filling, then we have another type of restoration called an inlay or an onlay, which is something in between a filling and a crown. A crown is basically a protective synthetic shell of enamel that replaces a patient's defective shell of enamel when the enamel has been filled too wide with too big of a filling and can now no longer support yet another filling. As we age, that's common. So we would remove the filling, remove the secondary decay, and restore the tooth, then put a protective shell over it called a crown. Crowns used to always be made by gold a couple hundred years ago. Then we moved to more non-precious metals which were more economic for the patient. And then we aesthetically had an improvement 50 to 100 years ago called porcelain fused to metal, where the coping, about 1.5 millimeters, would cover the body of the prepared drilled down tooth, and then there would be a shell of porcelain baked on top of it. Many people have them still in their mouths, functioning and servicing them well. On those specific teeth, however, when they break, you oftentimes see a black shell of metal underneath your tooth. It doesn't necessarily indicate there's decay present recurring around the tooth, but most crowns have an average lifespan of 10 to 15 years. Depending, of course, on how well the patient's oral hygiene is, they're getting cleans at a minimum twice a year and brushing, flossing twice a day. That number can go down considerably if they're not achieving those things. And I've seen crowns last 30 years, if possible, if the oral hygiene is spectacular. The newer materials we're using nowadays for crowns is all porcelain. It's called feldspathic porcelain, and they reinforce them with certain materials to give them added strength, like lithium disilicate. The other materials of very recent, within the last couple of years, which is really exciting. I know it sounds silly that I get excited about this material, but it's very exciting because we can deliver to patients with much more ease and predictability is a hybridized version of zirconia and resin. And we're going to get to talk about how dental fillings and larger restorations like crowns can be made now in single visits. There's a photograph here depicting amalgam, which again is the silver filling material within our tooth versus composite resin, which is the clear plastic material within our tooth. Aesthetically far better. This is an image of a cavity. So a cavity, Latin hole, is caused by the decay or breakdown process by bacteria. Often occurs in between your teeth, incipiently or non-harmfully at first, can be detected by dental x-rays routinely, and if caught very early on, we can now prescribe a certain type of toothpaste called MI paste amorphous calcium phosphate, otherwise we call it ACP, and it's a prescription toothpaste that can help speed up the remineralization process in a very, very small cavity. So we're at a point already where we have certain toothpastes in certain instances for patients that can help before a filling is even needed. When you do get your cleanings, there is an option to get a hand scale cleaning as most traditional cleanings go, or the use of a cavitron, which has been around since the 1970s, has greatly improved. Again, the importance of disclosing your full medical history. It sometimes is contraindicated with patients with implantable defibrillators or pacemakers because of the ultrasonic frequency can cause a discharge of the pacemaker. So again, very important for the stress of disclosing your medical information. This is an image of a cavitron. So it works at a high frequency and shoots water to debride the plaque and tartar from your teeth. Most commonly, most adults develop a majority of the harder tartar on the bottom 8 teeth by the tongue, because that's where a majority of the saliva is deposited. Again, saliva containing a lot of calcium ions can help harden the soft plaque in areas that it touches more. This is an image of a patient getting a cleaning done with a cavitron and a high speed evacuation suction. We use a higher volume suction when we do a cavitron-based cleaning of your teeth to prevent the aerosolized blood particles that can spray. Laser dentistry is up and coming. That is going to be the new toys that we look for in the next decade or two of dental medicine, especially for hard tissue or tooth preparation. We're not quite there yet as far as that is concerned. However, gum therapy for cleanings, for deeper cleanings, has shown great efficacy and it was cleared by the FDA. What it does is it removes the infected gum tissue with much less pain and discomfort than the prior surgical scalpel technique. So we touched on the topic of certain types of prosthodontic procedures. Again, prosthodontics is the specialty in dentistry and the branch that's concerned with the design and function replacement of teeth that are missing with artificial replacements within the tooth structure or replacing an entire tooth that's perhaps missing. We talked about fillings, filling inside a hole of a tooth, a cavity of a tooth, an inlay being a little bit larger than a filling. That's something that fills also within the body of the tooth structure. An onlay is something in between a very large filling and a crown. Perhaps if you've only fractured one of the cusps, one of the pointed parts of a molar, for example, the entire tooth doesn't always necessarily have to be completely drilled down to have the defective enamel shell replaced. Only part of the defective enamel shell can be replaced with an onlay. It's a far more conservative option. And now with the advent of zirconia, the strength is greater, so we have to drill far less to allow that to be retained on the tooth. Talked about a crown being a protective shell of enamel that covers the entire tooth if your tooth's shell has been fractured. And then we have bridges and fixed, otherwise known as fixed partial dentures. They're oftentimes nowadays made in zirconia or all porcelain. Sometimes they're still made in metal if the span or the turn of the arch in your mouth needs rehabilitating. We do still have certain limitations with our technology, in which case metals are still indicated. The older-fashioned metals are indicated. A bridge basically can replace anywhere from 1 to several teeth as long as it has strong supporting teeth in the front and back of the edentulous missing tooth space. So again, a denture can be fixed to your neighboring teeth as long as the supporting teeth are in good shape. That being said, bridges need to be replaced, just like a crown oftentimes needs to be replaced every decade, perhaps 2 decades. And we do have to oftentimes drill down those teeth considerably to support such a restoration. This is one of my favorite toys in the office that I cannot live without. It's a 3D CAD/CAM milling machine, or oftentimes referred to as a printer. And we nowadays are able to fabricate a crown, for example, or a large filling, an inlay or an onlay, in about 12 minutes via a digital laser-guided camera that takes an impression of your teeth. So if anyone has had an impression for a certain prosthetic in their mouth, They may remember that goopy impression material that often tastes terrible and takes about 5 minutes to 10 minutes, causes the gag reflex to be initiated. It's not very fun. Nowadays, we use a camera. It takes about 15 seconds to take imagery. And we take an image of the part of the jaw that we're repairing. We take then an image of the opposing jaw that hits it. So, for example, if we're working on your top right side, we take an image from the very back to your front tooth on the top right side. And then the same image of the bottom jaw from the bottom right side, from the very back to the front tooth. And then we take an image of how your jaws intercorrelate within one another, the top versus the bottom as you're biting down together. Several programs now exist. There was only one key contender about 10 years ago. It's made in Germany. This company is called Sirona, and 3M. There are several others now on the marketplace, which is great for dentists because it gives us a lot more options, and we'd like to see competition in the environment because advances occur much more quickly. And the way it starts is a pressed ceramic block. Again, feldspathic porcelain is inserted via that ingot into the machine's control arm, 2 robotic arms then, both with diamond-coated drills with a water recirculation device, essentially lay the tooth down to the exact structure that we would design for your tooth's crown. This example in this photograph right here is of something called an abutment. That's the base stump that the crown portion, the synthetic shell of enamel, sits on top of. In a healthy tooth, this would be your natural tooth, and that's pretty much what the preparation drilling would look like before the crown is cemented on top of it to give you the function and feel of a natural tooth. And certain people that lose their tooth, they have to have a dental implant, which I'm going to also touch on next, and it's a very exciting topic. This is an example of one of the most commonly prescribed dental crown materials used in the United States today. It's made by a company called Ivoclar Vivadent, and we refer to it as Emax. It is in a lavender state after that block is milled out by the 3D printer. Usually takes about 10 minutes to be milled out on the CAD/CAM machine. The little remaining sprue is polished off by hand, and then it's tried in the bisque raw state. So in the raw state, it's purple, lavender in color. We don't make you leave the office with a lavender tooth. I've had requests, but I said, no, you can't have that because it's not strong yet. It then goes into a kiln close to 2,000 degrees Fahrenheit for another 20 minutes, and it gets its shiny glazing coat. That's a front tooth, for example, a veneer or a synthetic shell of enamel that just replaces the front part of your tooth that may have been damaged, so we retain the tongue part. This is an image of a finalized crown after the kiln has been fired, again, replacing the defective shell of your enamel. And this is an example of a 3-unit dental denture, a fixed partial denture we refer to as a bridge. It sits on both adjacent teeth, and it has a synthetic tooth that floats on top of the gum. That needs to be kept very clean right there and right there where recurrent cavities and decay oftentimes occur if not kept clean. So my tooth broke, what do I do now? Well, we don't do anything is an option, but it's not the best option. We replace it with a dental bridge, which we just showed, or we replace it with more of the amazing cutting-edge technology that's now around called a dental implant. A dental implant is basically a titanium root surface. It's about the natural length of a natural tooth root that had to be removed if it was broken. And it's screwed into the root space where you currently had a broken root. It would be removed, and that titanium root would be screwed in place of that old root, of your natural root. The implant itself is hollow in the internal aspect of it, and that's what the crown, the tooth portion, is screwed into to retain it into place. There are a couple of different techniques in dental implantology. There's a rather aggressive surgical, most commonly used technique, and then there's the guided surgical technique, which I'm going to touch upon. That's what we do in our practice via the use of a cone beam CAT scan. This is an image of a dental implant. You can see the serrated screws there, and once it's placed into the bed of bone, we wait for the bone to grow around the threads of the implant to integrate it well. We talked about a 3D CT scan. In addition to that CT scan and the digital impressions, we create something called a 3D surgical guide or a printed stent, which is very similar to a sports mouthpiece and a guided sleeve that allows us to place now the implants with extremely great accuracy. We basically do your surgeries on the computer screen prior to you being in our chair. So every patient of ours has a digital surgery done on the computer screen. We email it and upload all the information to our laboratories to send us this pre-surgical drill guide. And most surgeries to place an implant takes about 10 minutes per one implant. We also don't have to slice open the gum tissues to have a good visualization of the bone anymore because we have a surgical guide. So what we end up doing is something called a tissue punch, and we place the implant through the guide into the bone. We wait 4 to 6 months on average for the bone to integrate around the threads of the implant, and then we place the abutment and the crown over it so it functions like a real tooth. The advantage of this versus a dental bridge is we don't have to touch this tooth, we don't have to touch this tooth or its neighboring structures. Just the problem at hand was repaired and everything else was left conservatively intact, which is a far better option. Many people have heard about, switch gears to the next topic, of orthodontics. That's the treatment of irregularities in our teeth, especially positions. The importance of orthodontics is to keep our teeth straight, to reduce the amount of plaque and tartar debris that can build up, especially in malformed, crooked, or misaligned teeth. There are options. Nickel titanium metal wires is the old-fashioned way of doing braces. The newer way now, of course, is again via our technological advances through 3D printers. We make a SLA model, a stereolithographic analog model, based on an impression of where your teeth begin. And the entire case start to finish is made before the patient's even sitting down in our chair at the next visit. A series of clear aligners, most oftentimes worn 2 weeks at a time, to slowly straighten your teeth to the ideal position. Example here of metal nickel titanium braces, a bracket cemented on each tooth, and they're torqued by the back areas of the wires every couple of weeks at the office, versus the clear aligners, which are manually changed out every 2 weeks. They're worn close to 24 hours a day, and it's an amazingly nice treatment. Periodontology, the study of dentistry that talks about the supporting structures of the teeth. We have patients that have no cavities but still lose their teeth because the supporting bony structures that support them in place are loosening from gum disease. Why is it necessary? It's necessary to keep the bony structures in support not only, again, of systemic disease issues, but also to preserve your teeth. And LANAP, the laser-assisted new attachment procedure, is the FDA-approved clearance recently that allows us to use laser treatment in scaling our gums. Again, a picture of the laser. That's a neodymium YAG laser. This company is called BioLase. There are several now in the market, and we would use to remove the infected tissue. Additionally, when we do a deeper cleaning, we call it a scaling and root planing, if it's not just a traditional cleaning, due to a deeper pocket area from that bone loss. We will put a time-release capsule of an antibiotic. Oftentimes now what we're using is a minocycline-based antibiotic. It's a microsphere that has a time-release capsule over a 10-day period, and it helps the attachment apparatus recur better. In addition, there's another material called chlorhexidine gluconate. It's a common soap sterilizing agent we used to scrub up in the operating room. It's used in a much lower percentage, 0.12%, in dentistry, and we place the perio chip or the chlorhexidine gluconate chip as well into these areas to help the reattachment occur of the soft tissue to the root of the tooth. So this is an example of the antibiotic powder that's placed in the cleaned area of the affected gum disease site, and that's a reattachment we potentially want to see. Removable prosthodontics, so removable dentures. There are options. There are full dentures, partial dentures, and some things in between. So what is better? A partial denture is always better than a full denture because it has things to hang on to, thus affording the patients more stability and retention. A full denture is sometimes needed on the top especially. It's far more stable than the bottom because on the top we have a palate where the denture can rest on. On the bottom we don't. We have that tongue that moves around. Additionally, important to note that if you have a drier mouth as we age, that's common, again, with side effects of certain medications. Dentures that are removable may not always fit well because they stick onto the gum with cohesion of your saliva. So the next option then would be implant-supported dentures, which is now the advent of how technology is moving over. There are a couple of different types of implant-supported options. There's an overdenture where your denture can snap on and snap off of a few small diameter implants in patients with very limited bone, or there's a fixed option where the denture is screwed on to the implants, which is the most elegant way we like to have dentures go. The cons of having a removable denture is that they're still removable and food can get impacted underneath it, and they move around when you're eating and functioning and speaking, so not as comfortable. However, much more cost efficient for a lot of patients. This is an image of a complete removable upper and lower set of dentures. They are often held in with adhesives, dental glues that are removable daily. This is an example of a partial denture made with a framework based in metal, mostly a cobalt-based metal and chromium. This is a model of a partial denture with no metal, and it has a thermoplastic resin-filled clasp that looks far more aesthetic, however, is not as rigid as a metal-based partial denture. So dentures, bridges supported to teeth, again, the advantages is that they're more retentive if teeth can hold a denture in place and can be cemented, doesn't have to be removed. Dentures and bridges that are supported by implants are better than dentures that are not supported by implants. A denture not having any implants in the mouth is supported by your gums. It doesn't do enough stimulation to the bone beneath the gums to stop loss of bone, otherwise known as resorption. It's a part of our aging process, but it's more importantly a part of the process whereby we don't have enough stimulation in the bone will conserve energy and shrink away. So the advantage of having implants to support your dentures is great because it puts an adequate amount of pressure within the jawbone to preserve the level of bone from deteriorating and resorbing away. This is an example of an overdenture supported by 4 micro-mini implants. The denture is removed daily and snaps onto them via an internal housing that's embedded within the denture space. This is an example of a fixed hybrid prosthetic, probably one of our most advanced techniques we have now available in dentistry. There are 2 options. There's one, a zirconia base that's exclusively printed by 3D printers in our lab done by our digital impression techniques. Usually anywhere from 4 to 6 implants will support an entire arch of dentures. They feel far more like real teeth. They function far more like real teeth. You, of course, cannot floss in between your teeth because it's a single entire prosthetic unit that's screwed down into the implants that are embedded in the jaw. Fixed hybrid prosthetics have been now the wave of our future to rehabilitate a patient with missing teeth. The advantage is, again, you don't have to remove them, and they look and feel a lot more like real teeth. It is a very costly procedure, unfortunately. The cost has been coming down considerably over the last several decades, and especially the last 7-8 years since the advance of 3D printing has taken place. They are more time-consuming to keep clean underneath with a water pick. This is the other example of a fixed hybrid prosthetic with a metal framework that's laser milled, and then again acrylic and porcelain teeth based on top. This is the more common way I like to do fixed hybrid prosthetics to rehabilitate a patient's edentulous jaw. Usually 6 implants placed in the bone, and on the internal surface they're screwed into the implants, and they really function like real teeth. And once they're integrated well, most patients will keep them throughout their life as long as they're maintaining their oral hygiene standards well. So in our final remarks, the best things to achieve in optimal oral health, flossing and brushing after meals and snacks, very important. Maintaining a hydrated environment in your mouth, noting changes to your dental provider, and trying to seek the best technological care to make your office visits far more enjoyable and comfortable. We try to do everything we can to keep our patients healthy in the shortest time frame in the dental chair as possible, because we know people don't like to come see us too much. But seeking preventative care is really important, at least twice a year. More often if there's any underlying health issues, to keep your health and periodontal health at the highest level possible. And then a diet, of course, that's not so coarse, not so hard, especially as we age. Our teeth have endured a lifetime of attrition and wear, So we want to preserve them to help our deglutition swallowing, chewing, eating, speaking as much as possible. I have some homework questions you have on your binders, and I'll recommend you look over those. And if there are any other questions, we'd like to take some time to talk. I'm available via our email address at our website, hawaiipacificdentalgroup@gmail.com. You can always call us by phone or text. We're available 24 hours a day, concierge practice, so you can answer any questions you have, 955-0008. Otherwise, I'd like to entertain some questions. I hope this has been informative and talking about the changes. I'm sure in a couple of years it's going to be a very different lecture. But toothbrushing and oral care is the most important. Thank you for your time, and I'll take some questions now.